Hi, so I'm back again, and we're going to talk about the human immune deficiency virus infections, or HIV. But I thought it would be good to have a general review about some of the things that are associated with immunity and just kind of review those a little bit. So as you can see on this picture, we have a number of parts of our body that contribute to our immune system, which includes the tonsils, the lymph nodes, the thymus, the spleen, um, Peyer's patches, um, the lymphatic vessels, and the bone marrow. The white blood cells are part of this immune system, and they're made inside the bone marrow. The white blood cells travel through the body inside of the lymph vessels, which are in close contact with the bloodstream. So it's not that they actually mix, but they run usually side by side or very close to the blood vessels. One of the things that I wanted to look at with these is to just remind you the function of the various white blood cells. Neutrophils engulf and destroy whatever substance is in the body that should not be there. Usually when we think about that, we're thinking about bacteria and or viruses. Lymphocytes attack specific pathogens depending on how that pathogen attacks the body. Monocytes or macrophages engulf and destroy similarly to the neutrophils, and eosinophils fight parasitic infections. Basophils release histamine, and it's one of the things that we see when the body comes in contact with allergens, whether that allergen be an allergy to a drug or a blood product or or pollen in the air. It causes the basophils to come out and attack, and when they do their little attack form, they make histamines. Um, and then plasma cells are what produce antibodies, and that of course makes it so that when our body sees that form again, we know how to fight it. And we have to really think about it as being a war that's going on in our bodies when we're thinking about infections and attack of things that shouldn't be there, like pollens. The immune system, and I felt like this really kind of showed it a little bit easier than some of the other displays that are out there. Some of the pictures get really confusing when we look at it. But it consists of dendritic cells. And the dendritic cells are a bit like spies. And they just kind of sit among the other cells. And if they detect any pathogens or foreign substances within the body, they will ingest some of them. And the molecules of the pathogens, which are called antigens, will appear on the surface of the dendritic cell. The dendritic cell then leaves the site of the infection and moves to the nearest lymph node. And it stays there for about a week, and it displays the antigens to the T and B cells that move through the lymph nodes. Macrophages means big eater. And these cells ingest and clean up messes that include disabled cells or viruses that have been flagged with antibodies and dead cells. When we look inside of the lymph node, what we see is the T helper cells. And the T helper cells are sort of like coordinator cells. They give instructions to the other cells by secreting certain proteins called cytokines. The T helper cells are responsible for activating other immune cells, and each T helper cell can only recognize one antigen. So if you have an antigen that comes up for chickenpox, you have a certain T helper cell that's going to recognize the chickenpox antigen. Then we have what's known as suppressor T cells. When the infection is gone, the immune system needs to get calmed down, or the killer cells would just keep on killing, including the good cells. So the suppressor cells, or regulatory cells, slow down or turn off the immune system to prevent damage to the good cells. Now, when we have a reaction, or especially anaphylaxis, these suppressor cells aren't doing their job and we're getting too much of a reaction. And those little killer cells are doing way too much. The killer T cells, or the cytotoxic T cells, destroy pathogen-infected cells by shooting an enzyme into them. And this makes the cells break into small pieces that can be eaten up by the nearby macrophages. And the B cells. When stimulated by the presence of a particular antigen, the B cells mature to become antibody factories known as plasma cells, which release antibodies specifically to target that antigen. So all of this is happening outside of the bloodstream. So when we look inside the blood vessel, the antigens are molecules from pathogens or foreign substances like bacteria or viruses. And the antigens appear on the surface of the cells that have ingested or been invaded by pathogens and cause the immune system to respond. Antibodies are released by plasma cells that are produced by B cells. The antibodies attach to the specific antigen that they were produced for, disabling and marking the pathogen for disposal. And that's when those macrophages come along and eat them up. The bacteria are single-celled microscopic organisms. While most bacteria are harmless, some are pathogenic and cause us harm. And viruses are very basic and tiny microorganisms that are not considered living. A virus is genetic material wrapped up in a protein coat. The viruses hijack cells and use the cells to replicate themselves. The viruses can be pathogenic and cause us harm. And we certainly are seeing that with the COVID viruses. And the neutrophils are often the first cells to leave the blood and fight incoming pathogens. They only live a few days, and dead neutrophils accumulate, and when they accumulate, it makes pus. So that's sort of the immune system in a nutshell. I'm not planning on giving you a big test about how the immune system functions, but I think it's really important for you to have a really basic idea, especially about how these killer T cells and CD4 cells and all of this kind of stuff, what their jobs are in the body, because it makes it so that you can understand the other aspects of that we're going to be studying. So when we look at the human immunodeficiency virus infection, it is a retrovirus that causes immunosuppression, making persons more susceptible to infections. So in other words, these viruses specifically target the cells of the immune system. About 1 million people are currently living with HIV, and about 50,000 new infections occur in the United States each year. The effective treatments that we've developed over the last few years has led to a significant drop in the death rates, and that's been great for people living with the disease. And in fact, now we're starting to these combinations of drugs are actually getting people to the point where they're not finding any of the virus living in their blood system. And so we're actually starting to talk about cures, although most people are not willing to put that word up there yet until more people are getting these positive results. So we're going to follow a little case study as we're talking tonight, and it's about AO. And he's a 20-year-old Hispanic male, college student, and he comes to the Student Health Center complaining of pain on urination. His urine test is positive for gonorrhea. And so what should you do? Well, at this point, obviously we're running his case study through an HIV lecture, so we kind of know where this is going to eventually lead. But at this point in time, all we know is that he has gonorrhea. So we're going to make sure that we talk about treatment options for gonorrhea. At the same time, we want to obtain a complete health and social history, including his drug and his sexual practices. When we look at the transmission of HIV, it can be transmitted through contact with certain body fluids. These include blood, semen, vaginal secretions, and breast milk. HIV transmission occurs through sexual intercourse with an infected partner and exposure to HIV-infected blood or blood products, and it can occur during pregnancy. The transmission can occur during pregnancy, at delivery, or with breastfeeding. The virus cannot be transmitted, however, through casual contact like hugging, dry kissing, shaking hands, sharing eating utensils, or using toilet seats, or casual encounters in any setting. It is not spread by tears, saliva, emesis, sputum, feces, sweat, respiratory droplets, or enteric routes, although people tend to be very careful and hypervigilant about these body fluids as well. Unprotected sex with an HIV-infected partner is the most common mode of transmission. And normally what we find is that it involves contact with semen, the vaginal secretions, and or blood. And all of these secretions have lymphocytes that, when the partner is HIV positive, may contain HIV. During any form of sexual intercourse, anal, vaginal, or oral, the risk of infection is greater for the partner who's receiving the semen, although the infection can be transferred to the inserting partner as well. Some of the sexual activities that may cause trauma to local tissues can increase the risk of transmission, particularly things like anal sex between males. Other things that we look at is prolonged contact with the bodily fluids. Women tend to be at higher risk for receiving the HIV contaminated semen. And then also, if there is genital lesions that have resulted from sexually transmitted infections like herpes or syphilis, it significantly increases the likelihood of transmission. When we look at contact with blood, anytime someone is sharing drug-using paraphernalia like needles, syringes, straws, or other equipment that could be contaminated with HIV or other bloodborne organisms like hepatitis B, sharing this equipment can result in disease transmission. Routine screening of blood donors to identify at-risk individuals, and testing donated blood for the presence of HIV has improved the blood supply safety. There was a time where there was no testing, and so what we started seeing is people that needed to receive pooled blood, like factor 8 for hemophiliacs. That increased their risk of being exposed to HIV, and a number of people with hemophilia developed HIV. Puncture wounds are the most common means of work-related HIV. And so we really, when we're thinking about that, we're thinking about needle stick exposures for nurses. With the risk of infection with a needle stick exposure is about 0.3 to 0.4%, or 3 to 4 out of 1,000. The risk is higher if the exposure involves blood from a patient with a high level of circulating HIV. So in other words, they have their HIV blood levels are very high. If it's a deep puncture wound or a needle with a hollow bore and there's visible blood, or a device that's used for venous or arterial access, it increases that risk. Splash exposures of blood on the skin with an open lesion do present some risk, but it is significantly lower than from a puncture wound. And in actuality, healthcare workers have a low risk of acquiring HIV at work, even with a needle stick injury. With the perinatal transmission, we talked just a minute ago about how it can occur during the pregnancy, delivery, or with breastfeeding. And on average, about 25% of infants born to women with untreated HIV will contract the infection. Treatment of the mother can reduce the rate of transmission to less than 2%. And fortunately, we test for moms for HIV now with their first visit for prenatal care. And that way, if we find that they're positive with that visit, it allows us to start treatment, which can improve the outcome for the baby. One thing I wanted to mention along with this as well is that even though we talk about breastfeeding as being potentially a cause, here in the United States, we would tell a woman with HIV, that she should not breastfeed because of the risk of transmitting the HIV through the breast milk to the child. But in third world countries, we would tell them to breastfeed, because if the mom is getting treatment, breastfeeding is actually less of a risk for that child than dysentery and diarrhea, because in third world countries, children die of diarrhea much more often than they die of HIV. So just one of those things to kind of keep in the back of your mind, but not something that we would do here in the US or in other industrial nations. When we talk about the pathophysiology of HIV, I'm not going to spend a lot of time talking about it, because I put a video for you from the Khan Academy about how HIV gets into the cells and how it works and all of that. And I think that they do a much better job of explaining it than what I do. So I am going to recommend that you make sure that you view that video. But the bottom line is HIV is a ribonucleic acid virus, and it's called a retrovirus because they replicate in a backwards manner, going from RNA to DNA. So you know that most cells replicate by starting out as DNA. The DNA splits, And in splitting this, we have meiosis and mitosis, and I'm sorry, but I always get those two mixed up. But basically, we end up with two cells that uh, that have one strand of their DNA in it, and then the second strand is developed, and we end up with DNA, and so we keep replicating that direction. Well, with HIV, we don't have DNA in the cell. We start out with RNA. And so instead of going from DNA to RNA to DNA, we go from RNA, it takes over the cell and starts making DNA, which is just really kind of a crazy thing. But that video explains it much better than I do. And specifically, it goes after the CD4 or the T cells as the target cell. And the CD4 cells are a type of lymphocyte, and the HIV binds to the cell through fusion. So I want you to think about, and I told you in my note that if you look at this infectious process, that there are certain words that you need to be picking up, because those are the words that describe the type of drugs that treat HIV. For instance, there's some that work at the fusion level. There's some that make it so the integrase doesn't work. There's others that make it so that the transcriptase doesn't work. So each one of these phases of the HIV attaching itself to the CD4 and working in that cell to replicate itself and to make more HIV cells has a drug classification that attacks the HIV at that stage of replication. So the components of HIV, like all viruses, HIV cannot replicate unless it's inside of a living cell. It's surrounded by an envelope made of proteins, including the GP120. So they use these fancy words like an envelope, but basically it's just a shell around the virus. And the HIV virus contains a core of viral RNA and proteins. Once the HIV is attached and fused with the specific protein receptor on the outside of the CD4 or the T cell, the HIV RNA enters the cell. And this triggers the release of the reverse transcriptase, which is an enzyme that transforms the HIV RNA into a single strand of DNA. This strand copies itself and becomes a double-stranded viral DNA. Another enzyme that's called integrase allows the newly formed double-stranded DNA to integrate itself into the host's genetic structure. So if you think about your drugs. We're going to have drugs that work at the fusion level. We're going to have drugs that attack at the transcriptase level. We're going to have other drugs that attack at the integrase level. And then there's one more. My mind's gone blank. And so we're going to have drugs that are specifically attacking the HIV virus at each one of these stages. So some of the consequences of integrase is that we get a newly formed double-stranded DNA that's infected with HIV because all the genetic material is replicated during cell division. And protease, which is the other one that I couldn't think of just now, which is another enzyme involved in the replication process, cleaves or sticks to the newly formed strands of HIV genetic material, and or not so much sticks, it breaks it into smaller pieces. And the new HIV viruses, or virins is the correct word, are then formed and released. And so protease inhibitors are another group of drugs that are going to act on that protease so that those new genetic material, the material is not broken into those smaller pieces, which makes it not usable. The CD4 T cell is then destroyed after the HIV virins are released. So one of the things that we look at when we're looking at HIV is looking at the CD4 and the CD4 T cell counts, and also at the viral load. If the viral load is very high, then it's a poor prognostic lab. If the T cell or CD4 counts are low, is a poor prognosticator. So what we find is that HIV destroys about 1 billion CD4 T cells every day. And during the first few weeks, the viral load goes up very, very quickly, and you can see that by this little red line that's here. And as a result of that, the CD4 counts are dropping. So we sort of have this stage where the HIV viral load hits a peak, and the CD4 levels hit a trough, so to speak. And they hit about the same time. And then over the next couple of weeks, we'll find that the viral load decreases dramatically, and the CD4 counts will actually go up for a little bit. And this is provided that no treatment is done at all. So during this period of time when the viral load is high and the CD4 counts are low, the patient has symptoms, and we'll talk a little more about those in a little bit. But then they hit this point where things sort of level out, and briefly anyway, the CD4 counts will actually go up, but then they start to drift down over time. Now everybody drifts down, but they'll drift down to varying degrees. And again, this is if no treatment is done at all. So then what we find is around 8 to 10 years out that the CD4 T cell count is getting really low, and they start having these opportunistic infections, which actually is what kills you, not the virus, but these secondary infections. And at that point, when they have these secondary infections, that's when we say that they have AIDS. And that's when we start seeing the viral loads increasing dramatically. Now again, this is if we aren't having any treatment at all. It's just sort of the general course of the disease. So for many years, the body can produce new CD4 cells, and it replaces the ones that are getting destroyed by the virus. But over time, it gets to the point where the body isn't able to replace those cells fast enough to replace the ones that are being destroyed by the virus. And obviously, since that's an important factor in your immune system, it impairs the immune function. The immune problems usually start when the CD4 cell counts get less than 500. And at this point, so many have been destroyed that there's not enough left to regulate the immune functional responses. The normal range for CD4 is between 800 and 12,000 cells per microliter. The severe problems and the diagnosis of AIDS comes when the CD4 count is less than 200. When it gets to 200, in that 200 to 500 range, it allows for opportunistic diseases, and these are infections and cancers that occur in immunosuppressed patients. And just remember that you can be an immunosuppressed patient and not have HIV. You could have some other immune disorder that would allow opportunistic diseases as well. And like I just said, the opportunistic diseases are the main cause of disease and disability and death with patients with HIV. So back to AO, he informs you that he has been sexually active since the age of 15 with both males and females. He states he's always on top, which means he's the inserting partner. He has had intercourse with 3 people in the last month and doesn't use protection. So what should you do next? Well, if you haven't already recommended it, further testing for other STIs, including HIV, is in order because he doesn't use protection. You want to inform him that testing is the only way to determine if he's contracted HIV, that negative results can relieve anxieties about past behaviors and provide opportunities for prevention teaching, and positive results can provide an impetus to seek treatment and protect his sex partners. You want to talk to him about ways to protect himself and others from sexually transmitted diseases like abstinence, non-contact sex, or use of barriers. Now, one of the things that happened when HIV first came up, when people started finding out that they were testing positive, they would get really angry. You know, that's part of the grief and grieving process. And it actually became kind of a, well, I don't know who gave this to me, but I'm going to make sure that I take as many people with me as I can. Well, laws were written after people started realizing those things were going on, and now somebody with HIV that decides that they're going to spread it as much as they can is actually charged with assault with a deadly weapon because of the potential for death from AIDS. So when we look at the timeline for untreated HIV infection, which is kind of similar to our peaks and valleys that look so much like our COVID flattening the curve things, what we see is that the acute infection occurs in weeks 1 to 3, and then the HIV antibody test becomes positive somewhere between 3 weeks to 3 months. And it's important to remember that the disease progression is highly individualized, and treatment can significantly alter this normal pattern that happens. And that the individual's prognosis is very unpredictable because it depends on whether they seek treatment early or later on. And then this information represents data from large groups of people, and it can't predict an individual's progress. So what we see is during that 1 to 3 month period of time, we have a acute infection, but then it becomes chronic. And that chronic period is that we often will see symptomatic infections show up between 8 to 10 years, and at 10 years plus is when people start showing symptoms of AIDS. So some places will phrase HIV infections as phases, and others give it the term acute, asymptomatic, and chronic. And so I decided I'd put both phrases on your slide. With the acute infection, you get flu-like symptoms, fever, swollen lymph nodes, sore throat, headache, malaise, nausea, muscle and joint pain, diarrhea, and in some cases a diffuse rash. Some people also develop neurologic complications like aseptic meningitis, peripheral neuropathy, facial palsies, or Guillain-Barré syndrome. During this time, the high viral load is noted, and the CD4 T counts are falling temporarily, but quickly return to the baseline or near baseline levels. Many people, including healthcare providers, mistake acute HIV symptoms for a bad case of the flu. And if you look at the symptoms, it does look just like a flu type reaction. Normally these occur about 2 to 4 weeks after the infection, so some people may not even remember the incident that exposed them to HIV. And during this time, they're highly infectious because this is when there's high amounts of circulating HIV. In phase 2, if left untreated, a diagnosis of AIDS is made after about 10 years from the initial HIV infection. The symptoms are generally absent or they're just very vague. And often people will continue to participate in high-risk behaviors. And so during this time period, people may not realize that they are HIV positive. The HIV risky behaviors become public health problems because the infected individuals are transmitting HIV to others even though they have no symptoms. And personal health is also affected because people do not know that they're infected. They have little reason to seek treatment, and they're less likely to make behavioral changes. Finally, in phase 3, they develop symptoms again. This is when the CD4 cells decline closer to 200 cells per microliter, and the symptoms become worse, and HIV advances to AIDS. To be diagnosed with AIDS, a person with HIV must have an AIDS-defining condition or have a CD4 count less than 200, regardless of whether or not they have an AIDS-defining condition. And as the viral load increases, symptoms like persistent fever, frequent night sweats, chronic diarrhea, recurrent headaches, and severe fatigue may develop. Some of the symptomatic infections that we may see include shingles, persistent oral or vaginal candidal infections, herpes, bacterial infections, and cancers. And the cancers tend to happen later when it becomes when that CD4 count is less than 200 and it has definitely become AIDS. Some of the other things I wanted to mention is, for instance, candidiasis or infections could be in the esophagus, in the bronchi, in the trachea, or the lungs, but they don't include oral or candidiasis, also known as thrush, as being one of the AIDS defining infections, because people could have thrush for other reasons. We might see cervical cancer. We may see cryptococcosis. We may see cryptosporidosis, cytomegalovirus. We may see cytomegalovirus retinitis. So with that, they would have loss of vision. They may have HIV-related encephalopathy. If they have herpes simplex, what we'd see is that it would last more than a month. It may spread to herpes bronchitis, pneumonitis, or esophagitis, histoplasmosis, Kaposi sarcoma, lymphomas, mycobacterial infections, pneumocystis pneumonia, also known as PCP, is one of the infections that when someone is diagnosed with it, the first thing that they think about is HIV. Recurrent pneumonia, salmonella septicemia, toxoplasmosis of the brain, and wasting syndrome due to HIV. So if they have these diseases, they are considered to have AIDS. Now, their CD4 counts may be fine, but these diseases only happen to people with severely immunodeficiency. And so that's why the AIDS diagnosis becomes the correct diagnosis at that point. Up until this point, it's just been an HIV infection. If they have that low CD4 count of less than 200, even if they don't have these infections, they are also considered to have AIDS and not just HIV, because a CD4 count of less than 200 makes them highly immunocompromised. So these are diagnostic criteria that's been established by the CDC. And like I said, at this point, their immune system is severely compromised. And so we're seeing these infections, malignancy, the wasting of the body, and HIV-related cognitive changes as well. If you notice, a lot of these diseases become infections of the brain. So this particular picture is of a esophageal, of an esophagus. And you can see on the left-hand side, it's a mild esophageal thrush, where the picture on the right is a little more severe. And it's one of the more common infections associated with thrush, is that it's spreading down into the gastrointestinal area. It rarely causes problems in healthy adults, but it's very common in HIV-infected patients. Kaposi sarcoma are these dark spots. They actually look more almost like a angioma or a raised area on the skin. They can be various sizes, and they can appear anywhere on the skin surface and on internal organs. It's caused by human herpesvirus 8, and they can be as small as a pinpoint, or they can be very large, and they appear in a lot of different colors, which You can't really see here. This guy tends to have them all about the same color, although there is some variance on his left arm. He's got one down by his wrist that's a little more red compared to the ones that are a little darker. Oral hairy leukoplakia is an Epstein-Barr viral infection, and it causes painless white raised lesions on the lateral aspect of the tongue. And it also is another one of the things that people can have as a result of the low CD4 counts. As I mentioned early, the pneumocystis jirovecii pneumonia, or the PCP, is also an opportunistic disease that doesn't happen in people who have normally functioning immune systems, and it definitely is one of those diseases that if somebody has it, there's an assumption that they have HIV. So AO tells you that he drinks at weekend parties and he smokes pot, but not recently. He reports no regular use of injection drugs, tobacco, or anabolic steroids, but that sometimes he gets so drunk he doesn't remember. So how would you rate his risk and why? Well, he's at high risk for contracting another STI or HIV because of his active sexual life with multiple partners, direct contact sex with same-sex partners, and the inability to recall possible exposure when under the influence, his unprotected sex, and his history of an STI. So the diagnostic studies, the most useful screening tests are HIV-specific antibodies and or antigens. Some of these may take several weeks to detect the antibodies, and during that period, we call it the window period. And when we say it may take several weeks to detect them, we're not saying that from when I draw blood or take a sample and test it, that it's going to take several weeks to get the result of the test. What we're saying is, if you come into me and say, I just found out that my partner has HIV and we had sex last night and I want to be tested, you may not test positive yet because your HIV viral load isn't high enough to test positive. And that's what we mean by this window period, where you could be positive, but we're not able to test to find out. And these are performed using blood or saliva. And the combination, or the fourth generation tests, can detect the HIV earlier. And this is just a schematic that shows, if it's positive, then this is what we're going to do next. If it's negative, this is what we're going to do next. HIV progression as a whole is monitored by CD4 cell counts, and it provides a marker of the immune function. And so what we would see is normally that we would see the T cell count slowly decrease. The other thing that we do is viral load, and the lower the viral load, the less active the disease is. And viral loads are usually reported as real numbers, like 1,260 copies per deciliter. The goal of treatment is to suppress the viral load to the lowest level possible, which is below the level of detection on a commercial assay. And so they'll often refer to it as being undetectable. Undetectable does not mean that the virus has been eliminated from the body or that the individual can no longer transmit HIV to others. But it refers to the fact that the amount of circulating HIV in the blood is below the level of detection that that test is able to test for. Abnormal blood tests are common. Some of the ones that are caused by can be caused by HIV. Some are caused by the opportunistic diseases or complications of the therapy, like decreased white blood counts, low platelet counts. The decreased white blood counts, especially the below normal numbers of lymphocytes, lymphopenia, or neutrophils, neutropenia, are often seen. The low platelet counts, which would be thrombocytopenia, can be caused by HIV, the antiplatelet antibodies, or the drug therapy. Anemia is associated with the chronic disease process and with the adverse effects of the antiretroviral therapy. In addition, we may see altered liver function, which is caused by HIV infection, drug therapy, or a co-infection with hepatitis virus, especially if they acquired HIV through drug injection. They're at much higher risk for having both HIV and hepatitis B, usually, although it can be B or C. And so it's really important to identify if they have a hepatitis B or hepatitis C because they have a more serious course than the patients that don't have it. And there's also a limited number of drugs that can be used because of the effect on the liver by the antiretroviral therapy. So it can cause liver-related morbidity and mortality. Resistance tests can determine if the patient's HIV is resistant to drugs that are used for antiretroviral therapy, or ART. The assays can help the healthcare providers know which medication may be effective. The genotype and phenotype assays are similar to cultures and sensitivity testing that's used for antibiotic selection. Some of the interprofessional care that we see is we do a lot of interprofessional care with the pharmacists because they will monitor labs and specifically the viral counts and the CD4 counts and look at those compared with the medications, also monitoring for side effects of the medication like liver disease. And so some of the things that we see is monitoring HIV progression and immune function and managing those symptoms. That's usually the healthcare provider. Also initiating and monitoring antiretroviral therapy. So pharmacists often will recommend therapy based on labs that are drawn and the patient's history. Also preventing the development of opportunistic diseases, detecting and treating opportunistic diseases, managing symptoms, preventing or decreasing complications of therapy, and preventing further transmission of HIV. Often that's done through education with public health nurses. And to accomplish these goals, we have to do ongoing assessments, clinical patient interactions, and patient teaching and support. Not only do we do that with healthcare providers, but we also do that with people that are support organizations within the community for people that are HIV positive. So one of the resources that I gave you was for AVOL, which is one of those support groups within central Kentucky. And this particular one, they have resources to provide transportation for people that are very sick but are still out in the community. Maybe they aren't able to drive. They provide housing for some individuals, especially if they have been kicked out of their housing. Even though we aren't supposed to have um, any prejudice towards people that are HIV positive, there are still some people that if they find out that somebody's HIV positive, they won't rent to them. They just give another excuse for why they don't rent for them because they know that they would be sued otherwise. And then they help get them, they actually do testing, screening testing on their facility site. And so if the test becomes positive, they help to arrange for follow-up with UK that has a HIV program and clinic that follows these patients and helps make referrals as needed for various other types of support that these patients may need. On the initial patient visit, we're going to gather baseline data like history and physical exam, and this will help us determine the patient's needs. We want to begin to establish rapport and use patient input to develop a plan of care. If you're working in one of these clinics where you're seeing these HIV patients on a regular basis, you'll get to know them very well. And just like the nurses that work with dying patients, they become very close. And when somebody gets sick and doesn't make it, it hits them as much as it hits the hospice nurses. We want to initiate teaching about the spectrum of HIV, the treatment, preventing transmission, and improving health and family planning. Yes, people still have babies when they're HIV positive, and there are definitely, they're encouraged to plan their pregnancies so that their CD4 counts are higher and their viral loads are low during their pregnancies, because that decreases the risk of passing it on to the child. And, like we said, 25% of people who are not being treated will pass it on to their child. That means 75% of those children never develop HIV. And if their viral loads are low and they're on a good treatment plan, it increases the probability of having a child that is HIV negative. Another thing, going back to what we were just talking about, is that when somebody comes in with an HIV diagnosis, they're in shock. And much of what's being said to them on their first visit, they won't remember it. It's just the same as people that are going in for a cancer diagnosis or some other disease process that's going to change the course of their life. They don't hear everything that's being said to them because it's too much of a shock for their body to take in and their mind to take in. And so you should expect that you're going to have to be repetitive with them so that they get all of the information that they need as time goes by. So AO returns to the clinic 3 months later after refusing HIV testing or teaching. He is now concerned as one of his partners was just diagnosed with HIV. He wants to help. What should you tell him about HIV testing? Well, HIV testing involves a small sample of blood or oral fluid for HIV-specific antibodies. It's important that you work together. Testing is the only way to determine if he has HIV. Early treatment and support is very important to his health, and you'll want to emphasize that with him. And you will provide him with information and support to help him understand and deal with his concerns. You would like to know more about his available support system. Is he on his own, or does he have people that are there for support? A lot of people have friends, but their friends are acquaintances. So does he have true friends? Does he have family? Or does he just have acquaintances in the community that he's living in? You need to know when the last risk of exposure occurred, and teaching is important to help prevent further STIs. The tests need to be repeated at intervals for up to 3 months after each possible exposure. Let him know if rapid testing is available at your clinic, and the staff has to be specially trained to perform that test. And I actually learned how to do that when I was volunteering with AVOL, but so much time has gone by since I used to volunteer with them that I probably wouldn't be considered to be qualified to do those rapid tests. Usually the results are available in about 20 minutes, but it is more expensive than the standard testing, and it should be verified with standard testing. It's important to protect himself and his partners from future risky behaviors during the 3-month interval until final results are available. So with drug therapy, the main goal is to decrease the viral load. You want to maintain or even increase the CD4 counts. The recommendations for starting therapy is chronically. Infected patients are actually summarized in your book on table 1413. Remember that HIV cannot be cured, but the antiretroviral therapy can delay the disease progression by decreasing viral replication. When it's taken consistently and correctly, it can reduce viral loads by 90 to 99%, which makes the adherence to the treatment regimens extremely important. The major advantages of using drugs from different classes, and usually that's what we see. In some cases, they may only have 2 different classes. Other times, they may have 3 or 4 different classes. We start calling that highly active, retroviral therapy, or HART. The major problem with most drugs used in ART is that resistance develops very rapidly when they're used alone or if they're taken in inadequate doses. It's almost like what we talk about with antibiotics, where we say just because you start feeling better doesn't mean that you stop taking the meds. And so if we find out that we have somebody who's taking their medicine inconsistently, then they're going to have more problems with their CD4 counts continuing to drop and their viral loads continuing to be high. So as a result, often we take 3 or more of these medications to get better results. Many of the antiretroviral drugs have dangerous and potentially lethal interactions, especially with herbal therapies like St. John's worts. And we need to make sure that we know the other medications that the patients are receiving when they are started on these antiretroviral drugs, especially over-the-counter drugs like antacids, proton pump inhibitors, and supplements. The opportunistic diseases complicate the management of HIV, and so we want to make sure that we prevent them rather than having to treat them. The number of opportunistic diseases associated with HIV can be delayed or prevented with adequate antiretroviral therapy. Vaccines like hepatitis B, influenza and pneumococcal vaccines, and disease-specific prevention measures. Although it's usually not possible to eradicate opportunistic diseases once they occur, prophylactic medications can significantly decrease morbidity and mortality rates in patients that do acquire these diseases. Advances in the prevention and diagnosis and treatment of opportunistic diseases have contributed significantly to increased life expectancy. We aren't hearing about thousands of people dying of HIV daily, and that was the case in the late 80s and early 90s, before we really understood about HIV. I think that that's one of the things that I've really thought about with this whole COVID thing, is having lived through the discovery of HIV and watched the fear that went through the population with HIV, and not knowing what this disease was that would kill people so quickly. It's, to me, the COVID is very similar, except with HIV you tended to live a little bit longer. So when we're talking about preventing transmission of HIV, there's something known as PrEP, pre-exposure prophylaxis. And it's a comprehensive strategy to reduce the risk of sexually acquired infection in adults at high risk. It should be used in conjunction with other proven prevention interventions like condoms, risk reduction counseling, and regular HIV testing. Tenofovir in combination with emtricitabine, which is also known as Truvada, and Descovy, is used to reduce the risk of HIV infection in uninfected individuals who are at significant risk for acquiring HIV. This combination is also currently used in combination with other antiretroviral agents for the treatment of HIV-infected patients as well. The cost of this preventative medication is about $1,758 per month. Now, that's what the cost of the medication is. Now, for some people, their insurance will cover it, and so they have a copay on it, and it's not nearly as expensive. But for somebody who does not have good insurance, this is a very expensive medication. The Truvada is going to be going generic at the end of September of this year. And if you think about, and the other one, it just came out last fall. So we know that one, they're going to be making money off of it for a while. But if you think about it, if you can't afford your medications, what's the chance that you're going to consistently use them? And so when you look at the cost of these medications, you can understand why people are not consistently taking their medicines. or why some population groups are not taking them at all. And of course, in the poor, that just means that we have a higher death rate and they develop HIV. So some of the things that we need to do in our assessments is don't make assumptions about who may be at risk. And we need to have candid conversations for the effective management of HIV. So in other words, you cannot get all embarrassed and everything talking to people about sex. A lot of people get this idea that they just can't handle asking somebody if they have anal sex. The other thing that you should know as well is that just because somebody is gay doesn't mean that they're engaging in anal sex. And when I'm saying this, that's from a male homosexual situation. And because every couple chooses to express themselves sexually differently, and not everybody has sex that requires insertion of a penis into some orifice. And so it's important that you ask these questions because, again, remember, the person who's receiving the semen has a much higher risk of developing HIV. The other thing that's important here is that you may have women that you talk to, but you need to find out whether their partners do drugs, because a woman who has a partner who does drugs has a higher risk because of the drug abuse, not because of the sexual activity, although there could be sexual activity as well in order to purchase their drugs. But it's back to, again, don't make assumptions about who's your person at risk. When you're talking to at-risk patients, you want to find out if they received blood transfusions or clotting factors before 1985. Again, we talked about the fact that we really weren't testing blood before then for HIV. You want to ask them if they've ever had shared needles with another person when doing drugs, or if they've had sexual contact with someone that's known to have HIV or may possibly have had high-risk behaviors that made it possible for them to have HIV. You want to find out whether they've had sexual experience with their penis, vagina, rectum, or mouth in contact with those areas with another person that could potentially be high risk for HIV, or if they've had a sexually transmitted infection. Based on these questions, the nursing interventions then can encourage the patient to adopt safer, healthier, and less risky behaviors, particularly in regard to sexual intercourse, drug use, perinatal transmission, and for nurses, your work issues. You want to assess their diagnosed patients thoroughly with a past medical history and medications that they're currently on, their functional health patterns, and the presence of symptoms using a systems review. You want to obtain both subjective and objective data, and you want to hopefully get early recognition and treatment that can slow the progression of HIV and prevent new infections. The goal for care are aimed at compliance with drug regimens, adopting a healthy lifestyle, beneficial relationships, their spiritual well-being in regards to life and death, and coping with the disease and its treatments. And again, these medications have some pretty significant side effects. And so there are some people that just go, I can't deal with the side effects. I can't work when I have these side effects, and I'm not taking the drugs, which is really sad because that decreases the time that they'll be here on Earth. Coming back here. As far as beneficial relationships are concerned, often these people with HIV suddenly are on their own. If they were not in a good relationship when they developed HIV, their partner leaves them. And often their families were not accepting of their alternative lifestyle in the first place. And these people are really on their own. And it's why we want to encourage support systems, support organizations, going to support groups, because then there's somebody that's going to understand what they're going through. And they're not going to be going through this on their own. We know that our immune system is very affected by our emotional state. And if you are on your own and you've given up, your immune system knows that. And to some degree, it gives up too. And so it's very important that we try to help them get into support groups to help them deal with their disease process. The primary prevention and health promotions are the most effective strategies for diseases that are chronic, like HIV. So when prevention fails and disease resolves, early intervention is facilitated by health promotion practices. As with most chronic and infectious disease, primary prevention and health promotion are the most effective healthcare strategies. When we start talking about early intervention, we're talking about tertiary prevention. Kind of review that whole idea of what's primary prevention, what's secondary prevention, what's tertiary prevention, and think about it in comparison to a number of different diseases, because almost every disease process that we have has a primary, secondary, and tertiary prevention strategy. Nursing interventions are based on and tailored to the patient's needs at every stage of HIV disease and can be instrumental in improving the quality and the quantity of their patients' lives. Our care plans need to be individualized and change as new treatment protocols are developed or as their disease progresses. So AO says he will not be abstinent, but is willing to use a condom during contact sex. What are the main points you need to cover when teaching about barrier methods of protection? Well, we want to make sure that he uses only condoms made of latex or polyurethane. There are, for those of you that don't know, there are actually condoms that are made of sheepskin, and so they do not protect against viral transmission to a receiving participant. It will prevent pregnancy, but it doesn't do much else. Store condoms in a cool, dry place and protect them from trauma. Do not use them past the expiration date. And some people will say, well, what do you mean? You know, they're made out of latex. What do you mean expiration date? The longer they go past their expiration date, the more possibility that they'll break during sex. And so you don't want them to break, so you need to make sure that they're not expired. Use only water soluble lubricants with condoms, because things like baby oil or Vaseline will cause breakdown of the latex and could cause them to break. You want to place the condom on the erect penis before any contact is made with the partner's mouth, vagina, or rectum. You're going to hold the condom at the base of the penis and remove the penis and condom from the partner's body immediately after ejaculation, and dispose of the condom by removing it, wrapping in tissue, and discarding. Never reuse condoms. When we're looking at HIV infection, it is preventable by avoiding risky behaviors, modifying risky behaviors, candid, culturally sensitive, language appropriate, age specific information, and behavior changing counseling. Every group of people have their way of talking about sex. If you are talking about sex in a very clinical manner, you may not be using terms that that person understands. So it's important to use the terms for sex that that person uses, so that they really understand what you're talking about. In decreasing as far as sexual intercourse is concerned, abstinence. Not very many people want to choose abstinence, but some people would rather choose abstinence than risk the fact that their loved one or their potential partner could develop HIV and AIDS. No contact, safe sex. It includes things like mutual masturbation and other activities that meet no contact requirements. Inserted sex between partners who are not infected with HIV and are not at risk of becoming infected with HIV are also considered to be safe. So in other words, if you don't have HIV and your partner doesn't have HIV, then you have safe sex. Use of barriers, including condoms. There's female condoms as well that may be an alternative to male condoms. And allows fairly normal sexual activity to take place. And also use of PrEP. In many cases, people are using PrEP as a secondary way of preventing HIV transmission to their partners. When we look at drug use, obviously if they don't use drugs, then that's going to help a whole lot. Some of the things you need to think about as well is that alcohol and tobacco can cause immunosuppression. Alcohol abuse can cause poor nutrition and a lot of other psychosocial problems. And so it exacerbates the problem of HIV infection. Usually when we're thinking about HIV and drug use, it's related to the sharing of equipment or having unsafe sexual practices while under the influence of drugs. Injecting equipment includes the works, The needles, the syringes, the cookers, which could be spoons or bottle caps that are used to mix the drugs, cotton, the rinse water, equipment used to snort the drugs like straws or smoke it like pipes, can also be contaminated with blood, and those shouldn't be shared either. Some communities have needle and syringe exchange programs. They call them NSEPs, that provide sterile equipment in exchange for the used equipment. The studies show that drug use does not increase. The rates of HIV and other bloodborne infections are controlled, and the overall cost benefit results in these communities that have these needle exchanges. Cleaning equipment before use can also reduce the risk by decreasing the chance of blood contact, and providing support for patients with substance use and referring individuals to professionals that can assist them in managing the psychological aspects of substance use is important. Also, self-help programs like Narcotic Anonymous, Alcoholic Anonymous, can also be beneficial. And you want to refer for help. As far as perinatal transmission, family planning is really important. I talked to you a little bit ago about how if a HIV positive woman wants to become a mother, she would have to understand the risk of transmission of HIV to her child, but also know that she needed to stay on her medication, that she should choose to become pregnant during periods when her viral load is low, and try to keep the viral load low throughout the pregnancy. They would also be followed more closely during pregnancy because of the risk of passing it on to the child. Obviously, we want to prevent HIV in women in general, but it still happens. And so we need to make sure that we're giving support to these women. Finally, as far as work is concerned, we want to adhere to precautions and safety measures to avoid exposure. The risk from occupational exposure is small, but it's still there. Should the nurse be exposed to HIV-infected fluids, post-exposure prophylaxis with a combination of antiretroviral therapy can significantly decrease the risk of infection. It started immediately, because with that case, the viral load has not started to increase when they start the antiretroviral therapy, and often they're able to not seroconvert over to HIV positive. We also we call that prophylaxis post-exposure prophylaxis, or PEP. And we want to make sure we report all exposures so that there's timely treatment and counseling. A lot of nurses will get poked and they'll say, oh no, it's okay. I know what their history is. I'm okay. No, you don't know their history. People don't always tell you everything that could possibly, how they're living their lives. And so they could be positive and you don't know. They could have been in the window and you don't know. It's important that if you get stuck by a needle and it is not a sterile needle. I mean, I've been stuck with sterile needles a million times. Like, I'm putting the cap back on so that I can take it out and give it to the patient. You know, we don't walk around with a needle down the hall. And I've stuck myself with the needle. And but I can say that I can count on my hands in all the years that I've been a nurse the number of times that I've stuck myself after that needle's been in a person. And it's scary no matter how you want to look at it because you just don't know. And you will be tested because they need to know whether you already had HIV or hepatitis at the time that you were stuck. So they will test you, they will test the patient, and they will start the PEP on you, and then they will do follow-up blood work to see whether you seroconvert over to HIV positive or not. The testing and counseling is the only sure method of determining HIV infection. The CDC recommends universal voluntary testing as part of routine medical care, especially if you're having sex with somebody that you haven't had sex with before. Definitely it should be one of those things where you are comfortable enough with that person to talk about whether or not you both get tested. Being tested for sexually transmitted diseases should be something that you do before you have sex with somebody. Usually doesn't happen, but it's something that ought to happen. An estimated 14% of people living with HIV are not aware that they're infected. The goal is to normalize the test and decrease the stigma related to HIV testing, to find hidden cases, and get infected individuals into care and prevent new cases of infection. So as you talk to AO about barrier methods of protection, he begins to look away and seems to lose interest. He finally says, I don't know if I can do this. So what are some cultural considerations that may be a factor here? In the Hispanic culture, it may influence an individual's acceptance of condoms. Condoms not only protect an individual from disease, but they also prevent conception. Contraception is problematic for many Hispanic cultures, either because of religious prohibitions or the desire to have children. Hispanic men may also have been raised with the cultural concept of machismo, which supports the notion that men are in control. And this may especially interfere with condom use in heterosexual encounters if condoms use is seen as weak and not using condoms is seen as a way to control the female partner. So for acute intervention, early intervention promotes health and delays disability. And so the nursing assessment should concentrate on HIV disease, on the early detection of symptoms, opportunistic diseases, and psychosocial problems. The patient will be confronted with complex treatment decisions, feelings of loss, anger, powerlessness. You know, a lot of that happens when, as far as feelings of loss and anger, they're not the same person. They know that now they potentially could die because of their behavior. And they start wishing for the me that was there before this exposure so that they could stop it. If it's somebody that they trusted, they become angry that that person that they trusted didn't warn them that they were at risk. They may feel powerless because that person didn't warn them ahead of time. They may have depression and grief. They may start to social isolate, kind of like we're doing now. They may have altered concepts of physical, social, emotional, and creativeness of themselves. They may feel like they've lost so much. And the possibility of death. They may even consider suicide. Patients and their family members, friends, and caregivers must also deal with the associated social stigma and discrimination that comes with HIV diagnosis. Antiretroviral therapy can significantly slow HIV progression, but it is complex. It has side effects. It doesn't work for everyone, and it's expensive. And we've already talked about just how that one combo drug, how much it costs. So now think about if you're on 4 drugs that you're taking 3 or 4 times a day. I mean, I remember watching something one day where they poured out the number of pills that this HIV patient needed to take daily, and it was a cup full of meds. Not a med cup, but a cup full of meds. So think about the cost of that, and think about trying to remember when those meds are due each day. These factors can contribute to problems with adherence to treatment, and adherence to treatment is really important because just like with antibiotics, we can end up with drug resistance. It's important that we give good patient and caregiver teaching on HIV treatment and follow-up. The interventions that you provide include teaching about advantages and disadvantages of new treatments, the dangers of poor adherence to the therapeutic regimens, how and when to take each drug, the drug interactions to avoid, and side effects that need to be reported to the healthcare provider. 2 to 4 weeks after they start on drug therapy or change their therapy, the healthcare the healthcare provider will test your viral load to find out how the drugs are working. The viral load is reported in absolute numbers, and you'll need to keep track of them. So they probably, will recommend that they get like a notebook to keep track of all of these things. It's best if the CD4 count can be above 500 to 600. If it's reported in percentages, they would want it to be above 14%. Usually patient readiness to start therapy is an important concern because they're in shock. Guidelines on when and how to initiate antiretroviral therapy are based on the degree of immune suppression. You want to avoid burnout and non-adherence. And so it's recommended when the immune suppression is great. The issues to consider when selecting an initial drug regimen include the ability of the patient's HIV to resist specific drugs, potential medication side effects, existing comorbidities, and dosing schedule. It's a critical decision because the first treatment regimen is generally the patient's best chance for success. So they'll probably do some of those additional lab tests to find out which drugs are going to work the best for that patient. Adherence to drug regimens is critical to prevent disease progression, opportunistic disease, and viral drug resistance. And an individualized approach is best. And strategies to improve adherence include simplifying the regimens. So, like for instance, the medication that's a combination drug, that makes it easier because they only have 1 pill to take instead of 2. And use of reminders. They may have to set an alarm on their watch or on their phone to remind them to take their meds. and getting help from their partners, their family members, or their friends is going to be helpful as well. And again, we talked about getting help um, from support groups as well. We when we want to support a healthy immune system with adequate nutrition, getting current vaccinations, health habits, things like um, drinking in moderation or eliminating alcohol and tobacco, keeping up to date with the recommended vaccines, getting adequate rest and exercise, and reducing stress, and avoiding exposure to new infectious agents, accessing counseling, and getting involved in support groups. You want to teach the patients to recognize symptoms that may indicate disease progression and or the drug side effects so that prompt medical care can be given. So AO tells you that he really cares about one of his partners. What do you tell him about informing his previous sexual partners about his gonorrhea? And what should he tell them about the HIV infection if he tests positive? So think about that. With acute exacerbations, HIV has no cure. It continues for life. It causes physical disability. It impairs social, emotional, economic, and spiritual well-being, and ultimately it leads to death. It does have periods of time where the CD4 counts go down and they get infections, and then they're able to get the CD4 counts back up again, and the infections go away for brief periods of time, but then it exacerbates and comes back again. As far as ambulatory care is concerned, stigma can lead to discrimination and can result in social isolation, dependence, frustration, low self-image, loss of control, and economic pressures. This is not one of those things where you go walking up to your boss and you go, oh, by the way, I have HIV. Not very many people do that because there is a fear that you're going to lose your job. There's a fear that you're going to lose your housing. There's a fear that things aren't going to go the way they're supposed to go legally. And we've talked a little bit about that. Even though it's illegal, according to the ADA, there's still a lot of stigma and discrimination against people who have HIV and AIDS. Some of the common physical problems with the drug side effects include anxiety, fear, and depression, diarrhea, peripheral neuropathy, pain, nausea and vomiting, and fatigue. I would say some of the more common things are the diarrhea, the peripheral neuropathy, the nausea and vomiting, and fatigue are some of the more common side effects for the medications that are used for antiretroviral therapy. Some are very specific to the drugs themselves. Some of the metabolic disorders that we may see is lipodystrophy, and that can be as a result of hyperlipidemia, including elevated triglycerides, elevated low-density lipoproteins, and decreased high-density lipoproteins. Lipid abnormalities are generally treated with lipid-lowering drugs like statins, dietary changes, and exercise. Insulin resistance is treated with hypoglycemic drugs and weight loss. Bone disease involves osteoporosis, osteopenia, avascular necrosis, and the bone disease can be improved with exercise, weight-bearing exercises, dietary changes, calcium and vitamin D supplements. It's not clear why things like lactic acidosis, renal disease, and cardiovascular disease develop, but it's probably from a combination of factors like long-term infection with HIV, the side effects of antiretroviral therapy, just a general predisposition, and chronic stress. Having a chronic disease gives you chronic stress. Lipodystrophy results in changes in body shape that's caused by redistribution of fat in the abdomen, the upper neck, and breasts, along with fat loss in the arms, legs, and face. Management of these metabolic disorders focuses on early detection, symptom management, and helping patients cope with emerging problems. Also, a frequent first intervention is to change the antiretroviral medication because some of the drugs are more associated with those disorders than others. So 1 year later, AO returns to the clinic and with complaints of night sweats and a productive cough for a week. His CD4 count is 76. He's lost 13 pounds in the last month, and his record shows a history of a positive PPD. So what do you think is happening? Well, with all the things that are going on, he has an opportunistic infection. His CD4 is below 200, so he is likely HIV positive, and he probably has AIDS at this point. His indication is that his Mycobacterium tuberculosis, which some of those symptoms are associated with the tuberculosis, but some of them are associated with his HIV as well. When we look at end-of-life care, we focus on the nursing interventions like patient comfort and promoting acceptance of the finite nature of life with our patients, that we're all going to die at some point. This is how their life is going to end. And helping others deal with loss. You want to maintain a safe environment. You want to remind that sometimes the treatments just don't work. And sometimes the patient's HIV has become resistant to all the available drug therapies. In other cases, a patient may make a decision to just not have any further treatments, and they allow the disease to progress towards death. Some of the things that we need to think about is gerontologic considerations, like the fact that the number of persons over the age of 60 living with HIV is anticipated to grow. That's because some of the people that were young in the 80s and 90s are now getting to be 50, 60 years old if they lived past that initial not knowing what caused the diseases. Also, we have to realize that we have a group of people that grew up in the 60s. There was free love, but the big concern at that point was getting pregnant. And so to some degree they were protected at the time, but now that they're older, they still have that mindset of free love. And they're having sex in their 60s and 70s and 80s. And they're picking up STIs at higher rates than younger people. And their HIV diagnoses are coming up higher as well. In general, they don't tend to die from opportunistic infections because they're still susceptible to the same diseases that come to all older adults, like heart disease, cancer, diabetes, kidney disease, and but because of their HIV infection, they may experience them at an earlier age. They may be at higher risk for comorbidities due to the effects of the medications used to treat HIV. Also, polypharmacy is a concern because the multiple medications that older adults may have to take could have interactions or be potentiated by the HIV medications. It may be difficult for the older adult to get appropriate health care and support if they're ashamed or hesitant to tell anybody that they have HIV. So, as a nurse, you need to recognize that HIV is a chronic disease and it will affect an increasing number of older adults. And so, you need to be aware that you could be taking care of an older adult who's living with HIV infection, as well as all the other things that older adults deal with. There's several questions here at the end. I did include these in your PowerPoint. If you look into the presenter's notes, you will see the answers to these questions. I'm not going to take additional time to go through these at this point in time because there's plenty of things that you guys are going to be watching and listening to in addition to this. Please make sure that you do the HIV section in Pharmacology Made Easy, the immune system section, because that does go into these drugs in more detail, and I did not go into those because you do have that resource. And so I wish you all a great evening, morning, whenever you're happening to listen to this, and miss talking to you guys in person and seeing your responses to various things that come off the top of my head. I'm looking forward to this whole COVID thing being done so that we can see each other and talk face to face. Good night.